this is the second part of our Woo You Glaucoma series, and I'm really excited for Dr. Saboori to be with us tonight. My name is Dr. Stephanie Wu. I am the host of Wu University and the founder of Wu University. So it's my pleasure to introduce Dr. Saboori. He is a native Louisianan who grew up in Iran, and he did his medical training at Vander University School of Medicine and his residency at the Kresge Eye Institute, completed a fellowship in surgical glaucoma at Case Western Reserve University. Dr. Saboori now works at Meadows Eye, and he is their first anterior segment surgeon and focuses primarily on cataract surgery and glaucoma. Dr. Saboori is a good friend of mine. He's a great surgeon, and I'm really excited to have him. So let's please welcome him.
All right. This is my financial disclosures. The only thing relevant is the area pharmaceutical. Well, Dr. Wu, thank you for inviting me to speak. It's a pleasure to be able to speak to you guys. I'm going to try to stay away from the speaker a little bit since I hear a little bit of echoing. Can you talk louder? Sure. Let's see if I can bring the microphone a little higher. Does that work? I think I can just hold it. All right, so today we're going to be talking about an overview on glaucoma pharmacotherapy. Just a little bit about us. I work at Meadows Eye, used to be called Meadows Retina until last year. And after I joined, they decided to be complete and call it an eye. The middle here is like the Berlin Wall. This is all the retina guys with their black on the right-hand side. And all of us anterior segment guys on the left with our blue. We'll see if the tradition keeps going. What do we offer as far as treatments for glaucoma? So these are our surgical options. Obviously, cataract surgery, you're all aware, helps with the pressure. But we offer basically everything there is for glaucoma treatment surgically. And they're listed here. So for today, we're going to be doing a quick intro on glaucoma, not go too in detail. We're going to brush over all of our topical IOP lowering medications and talk about novel drugs and delivery devices. So as you know, glaucoma has a 3.5% global prevalence. It's the #1 leading cause of irreversible blindness. And the mainstay of treatment at this point is medications or eye drops. And, even though surgeries have become safer and more efficacious, we still treat most of our patients with medications, and we're hoping to make that a better treatment. As you know, IOP lowering, all of our large studies have shown that helps slow down or stop the progression of glaucoma. But we know that there's more than just mean IOP, that diurnal variation plays a big part in glaucoma progression. And with medications that tend to have longer half-lives, we tend to have better diurnal control of our glaucoma. We know that even though aqueous production decreases at night, pressure tends to go up. And that's thought to be due to UV scleral outflow decrease at night, which is why PGAs work so well at night, because it increases UV scleral outflow. So to lower IOP, you gotta either change the facility outflow, you gotta change the aqueous production, or you gotta change the EVP. And up until recently, we didn't really have any way of changing the EVP. So the first class of medications we'll just go over is aqueous suppressants. So they're the adrenergic agonists, the beta blockers, alpha agonists, and the CAIs. I think this is the first and last meme you're gonna see. I tried to be professional, pick out all my memes. Sorry, guys. Speaker last night was serious. I'm talking about glaucoma in front of a lot of people. There's a lot of pressure. All right. So the beta blockers, they decrease aqueous production by 20 to 50%, lower IOP 20 to 30%. They are not very effective at lowering IOP at night. We've had sleep lab studies, mostly at UCSD, showing that IOP does not really get affected much at night with timolol. In my clinic, I only do TAM dosing for timolol, except for patients who have weird sleep habits, like if they work at night. In those cases, we're not really sure, is it the circadian rhythm or is it when the patient sleep that affects the pressure? So in those patients, I always keep it PID just to be on the safe side. But otherwise, I do QAM dosing for timolol. Local side effects are pretty mild, but systemic side effects tend to be wild. You hear the rhyme there? Anyone? All right. The systemic side effects, bronchospasms, so be mindful of COPD, asthma, bradycardia. So, be mindful of your older patients that may have heart block. Ask them about heart issues. Hypotension, again, especially orthostatic hypotension in our elderly patients. We don't want to cause a fall or a fracture. CNS, depression, fatigue, even mood depression is a side effect. An odd one that you may not think of, but you may want to think of in your younger men can be erectile dysfunction as well. Decreased exercise tolerance, decreased HDL, especially in men. And glucose hypoglycemia, a lot of times patients have less sensitivity to it. This is just a list of what's on the market. I don't need to go over that in detail because most of you are aware, but it's up there for you. So the alpha agonists, basically we have the older ones that we're not going to talk about and somewhat newer ones. So the non-selectives we no longer use, but the alpha-2 selectives, again, they don't work really well at night. It is the only glaucoma medication that's class B in pregnancy. So if you have a pregnant patient, that's the one to use without any hesitation. It does have some systemic side effects and also significant local side effects. With the 0.2%, usually have about a 20% allergy follicular conjunctivitis rate, and you can get contact dermatitis too. Systemic side effects, usually somnolence in elderly patients and dry mouth. So aproclonidine doesn't cross the blood-brain barrier, so it's safe in children, but brimonidine is an absolute contraindication in neonates and young kids because it can cause CNS depression and death. These are the formulations available. So basically, the alpha-GAN 0.1% P has the lowest dose, the most gentle preservative purite, lower rate of allergy formation long-term, but coverage is always an issue. And then you have the combination meds. So looking at brimonidine versus timolol in patients with normal tension, you may have all heard of the low tension study group. They followed patients for about 4 years and randomized patients to brimonidine versus timolol and looked at glaucoma progression. So during the study, about roughly 10% of patients in the brimonidine group had progression on medication versus close to 40% of patients in the timolol group, which is oddly very high. The IOP reduction, interestingly, was similar between the two groups. So the question is, does brimonidine do something that's protective of the optic nerve in normal tension, or does timolol do something that's detrimental to the optic nerve? We don't really know the answer. There is studies in animal models, pressure injury studies of the optic nerve that show brimonidine could potentially have some neuroprotective benefits, but nothing that's been proven in humans. And then the other thing to note in this study, the brimonidine group had 20% dropout due to allergy within the first year, which was also higher than my personal experience, at least. Next group of aqueous suppressants are the CAIs. So they lower the pressure about 15 to 20%. So not as effective as some of our other categories, but there is some conflicting evidence that it may help with the nighttime IOP. So it is something that I consider in my normal tension patients as well. There are some local side effects, endothelial dysfunctions, and patients with Fuchs, they may notice more vision variation. Stinging with dorzolamide is pretty significant. So I always counsel the patients it's normal, don't stop the medication. And then allergy, contact dermatitis especially, or papillary conjunctivitis tends to be common in this group as well. Systemic side effects can have bitter taste. And then these are the available formulations. The last two are oral, the only class of medications that we have that are oral. So for the oral meds, we have to rarely use them in special cases. I don't like to have patients on them long term, but sometimes it's a bridge to surgery. Sometimes it's a bridge for other types of glaucoma that may become less elevated over time, like steroid response. But you can have bitter metallic taste, especially with carbonated drinks. People hate drinking beer with it, which I guess it's a good thing. Paresthesias, lethargy, confusion, weight loss. I've had patients lose quite a bit of weight pretty quickly on this medication. Some are happy about it. And hypokalemia, that's one thing that I always counsel my patients, increase the amount of intake. So I always counsel leafy greens, avocados, bananas, etc. And keeping hydrated, that's important as well. Higher risk of kidney stones, especially here in Las Vegas. And then the last thing that really you don't want to see is aplastic anemia. In my 7 years of doing this, I've had one patient who ended up in the ICU actually with aplastic anemia after Diamox use. So even though it's really rare, it happens. So, don't use these medications lightly. Cholinergic agonists, that's the oldest class of medications we got. First started using them in the 1800s. And they work by increasing the conventional outflow. So they stretch the TM and allow more fluid through the TM. They do come with some side effects. Local side effects are miosis. A lot of times patients call and say, my vision got dark. And your front desk is like, oh my God, there's a retinal detachment, come in right away. But it's just a small pupil. And you can have, induced myopia, accommodation, risk of retinal detachment, especially in myopes. And paradoxical angle closure, that's something that, is against the norms, but in patients who have weak lens complexes, so spheriphakia, pseudo-X, and also malignant glaucoma is another one where you can get worsening angle closure. Systemic side effects, you can get cramps, diarrhea, headaches, pretty common, about a third of patients, bronchospasm. And it's contraindicated. Well, I wouldn't say necessarily contraindicated, but in patients who come in with severely high eye pressure, like for example, acute angle closure patients, we always give Pilo, but it actually doesn't work when the pressure is 60 or 70. You have iris ischemia, it's not going to do anything. It's good. It's a good adjunct once you do an AC tap and lower the pressure, and then it will work. And then relative contraindication for high myopia and patients with intraocular inflammation. So where do I use this medication in my practice? I use it, perioperatively when I'm doing like an LPI, for example. I use it after my goniotomy procedures. Even just once a day at night tends to, in my experience, help keep those otomy clefts open and keep the pressure down. Plateau iris, and occasionally for open angle glaucoma, especially in elderly patients who are really risk averse and don't want to have surgery no matter what. And they're pseudophakic. It works at lowering the pressure. So it's burdensome, but it works. So our most effective group as of yet are the prostaglandin analogs. They lower the pressure on average about 30%, and they target the PGF2 alpha receptors. They improve the UV scleral outflow by basically altering the extracellular matrix. There's actually a newer class of medications being developed in this group that is going to be affecting broader PGE receptors. The studies are all enrolled, I believe, and it's being developed by Santen. And then in this group, Bimatoprost, the ones that's a little bit different than the rest, it's a prostamide. But if you look at the XLT study, the Xalatan versus Latanoprost, Travatan versus Bimatoprost study, that there was no significant difference in efficacy between those three medications. So local side effects that you're mostly all aware of, I'm sure, is darkening of the iris. It's not very common, but it does happen, especially in patients with mixed blue-green or mixed, green-brown or mixed blue-gray iris color. Periocular skin pigmentation, that's probably what I see most commonly. Hypertrichosis. Prostaglandin-associated periorbitopathy, that's more common in patients who've been on it for a long time, sunken, eye sockets, tight eyelids. And then I would use caution in patients with history of HSV keratitis, because there's some evidence that it may reactivate HSV keratitis. Systemic side effects are rare. These are just some pictures of what we talked about earlier. So a few things you may have all heard about prostaglandin analogs causing CME. Not infrequently do I get referrals from retina specialists to stop patients' prostaglandin analogs medication because it's causing CME. In my experience, I think out of tens and tens of patients where I've been asked to do that, I think maybe one patient, a slight maybe, that CME went away because we stopped the prostaglandin analog. But in my experience, it's not a big factor. There is studies to show that there is no proven association, but there's also studies that show there might be some association. So the jury's still out with that. This study actually looked at patients who were on beta blockers and prostaglandin analogs, and beta blocker actually had a higher relative risk of association with CME than prostaglandin analogs did. But the study, I think, had some flaws as far as the design, so I would take it with some grain of salt. And these are the available formulations, the last one being the newest one, which is the Vyzulta. It contains a nitric oxide moiety that but also contains a higher concentration of latanoprost compared to Xalatan. And they're all QHS dosing. So a little bit of a timeline of approved meds. We talked about pilocarpine being the first, again, 1800s, long time ago. Then we got our second one, epinephrine, in the 1920s. And in the 70s, we got beta blocker. So if you saw a lot of patients, I actually, even when I was a resident, I had an older attending who still had patients on Timolol and Diamox. Yeah. Anyways, that was all we had, and up until the 90s. So those three medications. And, in the 90s, we got a few new classes, the carbonic anhydrase inhibitors, the prostaglandin analog, and the alpha agonists. And then it wasn't until 2017 that we really got a new class of medication, and both Vyzulta and Repressa came out that year. Even though Vyzulta is still classified under the PGA group, it does have the nitric oxide side to it that theoretically releases the trabecular meshwork and increases outflow. through the trabecular meshwork. If you looked at the VOYAGER study, you see that the group that received Vyzulta had a 34% IOP reduction, or a 9-point IOP reduction, compared to 7.8 or 7.77 in the Latanoprost group. So, about a 1.2 millimeters of mercury higher IOP, mean IOP reduction. And you may not think that is much, but every point matters, and every point of IOP reduction is 10% decreased risk of glaucoma progression. The next class of medications are Rho kinase inhibitors. So Rho kinase causes cell contraction and actin myosin binding in the trabecular meshwork, fibrosis in the trabecular meshwork. So by blocking that, we're causing relaxation of the trabecular meshwork and increased flow through there. The journey to Notarsidil started in the 80s with Dr. Epstein over at Duke. And, the thought was, we know glaucoma is a disease of the trabecular meshwork. Why are we treating all these other parts of the eye that are not affecting the disease part? So that's how the whole idea came to fruition. The other thing that is, unique to ROCK inhibitors is the epispiral venous pressure lowering. You can see in the histology slides on the left, you have about a 67% increase in the cross section of the epispiral veins, which could also explain the hyperemia. It's always discussed with my patients. Your eyes can get red, but that's because the medication's working. And this is just a slide from the FDA studies showing that over about almost 2/3 of the patients had pressures under 16, and 1/3 of the patients had pressures under 14, 3 times as likely as Latanoprost alone. So those are huge for our normal tension patients. And this is just going over the MOST study, which kind of confirms our clinical findings. No matter where we add Repressa in the treatment paradigm, we tend to get the same pressure lowering, about 4.5 points of pressure reduction, whether it be the first medication or the last medication, third or fourth line medication that we add, and basically defies the law of diminishing returns that we usually are used to seeing with multi-drug therapy. The place to also keep this in mind is when we have those low to mid-teens patients on medication that we need to have lower pressures on. That works really well there. So this is a study that just came out recently, hot off the press, and it kind of basically proves the mechanism of action and also kind of verifies how steroid response works. So, we've all been taught that steroid response is affecting the trabecular meshwork and causing decreased flow through the trabecular meshwork. And when they studied Notarsidil in patients with steroid response, they saw that the IOP lowering was much more robust than in patients with primary open-angle glaucoma. This just covers the side effects. Most commonly is hyperemia. I always warn my patients, your eyes can get red. It'll be red, more red initially. Don't freak out. And most of the times, by the time they come back to me in 1 month, you're going to have that 5 to 10% of patients who are not going to take it. But the rest, they're taking it, and it's helping them lower their pressure. And then verticillata and hemorrhages. They're usually small petechial hemorrhages. You can see that in the upper right corner. Those are actually pretty significant petechial hemorrhages. Usually they're less noticeable than that. On the left side, you can see the verticillata, and then in the bottom slides, you can see this more rare side effect that you can see. I've only seen two patients with it in the past 3 years, and that's the honeycombing in the cornea. It's reversible, though. Once they stop it, it goes away. So we're going to switch over to the novel drug delivery part of our talk. So this is a response to the downfalls of eye drops. This is a video that I borrowed from a friend at, let's see if I can play it, over at Vance Thompson. Let's see. And basically the doctor asked his patients to put in eye drops in front of them and see what they do.
Too much.
That was half of the bottle there that was gone. It just doesn't look safe. So, you know, there's a lot of problems with drop therapy, and unfortunately it's, you know, what we have right now. But, you know, patients like this, they're going to have problems with the medication running out weeks before when it's supposed to. Or having issues with contact dermatitis because it's all over their face. Other issues, adherence, that's a big problem. So this is just a graph that I borrowed from a study out of Hopkins that showed at the end of one year, you were having less than half of the patients actually being compliant with their medication. And, you know, I like to believe all of my patients when they tell me they take it every day, every single time. But we know it's just not true. That's a problem because you get pressure fluctuations. We talked about pressure fluctuations. They cause progression of disease. And then finally, side effects. You know, we've seen it all. Drops can be ugly. So this is just a diagram of what is being worked on, what's in the pipeline. We're looking at surface implants such as, you know, contact lenses, drug delivery devices, intrascleral pumps, injections into the AC, injections into subconjunctival space, punctal plugs. So we're just going to quickly go over all those different things that are in the pipeline. So this is a Bimatoprost ring. Actually, I haven't seen anything published recently, so I'm not sure where the studies are at, but, you know, I first heard about this maybe 9 years ago at the American Glaucoma Society meeting, and there is a more recent publication on it, but again, I just don't know where they are in the study phase. But basically, this is a soft, pliable ring that goes under the eyelid and stays just under the eyelid. You can sometimes see the little bit of it at the inner canthal area, and you know, the efficacy of it wasn't as high as topical Bimatoprost in the initial studies, but we know that it's going in every day, all the time. There wasn't actually as much hyperemia because it's such a small dose that's being released and it's preservative free. But the main side effect was mucoid discharge, which is likely a foreign body issue with the ring. Next, we have Latanoprost eluting contact lenses. These have been studied in monkeys and so far look promising. They're going to make it to humans hopefully soon. And this is just a cool slide from the paper that kind of freaked me out. I was like, oh my God, who's going to wear this contact lens? It looks scary, only to find out the monkeys have black sclera or something like that. So, gel forming drops. So Otero Therapeutics working on a delivery device called a Soli drop that basically it's a drop that you put in the eye, but it forms into a solid gel in the lower fornix. And you can add any number of medications to it. So it's a delivery vehicle, and they're looking at a number of different drugs to be added to this. They're going to be preservative-free medications, and they're going to be released at small doses. if you look at studies for glaucoma meds, let's say we put a drop of timolol in the right eye, usually you see a little bit of pressure lowering in the contralateral eye. And the dosage is so low that there was no pressure lowering in the contralateral eye. This is a Todd, basically, not to be confused with Todds, I guess, for the fashion-forward people. I'm looking at you, Natalie. Anyways, these are developed by Amorphix Therapeutics. They're soft pharmaceutical implants. So far, they've embedded timolol with plans to embed other medications in them. Release is over 180 days. So, you just put in an implant and leave it there for 6 months. That sounds like a pretty good deal to me. Punctal plugs. So Ocular Therapeutics, which is the company that makes Dextenza, which you may be familiar with for post-operative steroid treatment. It's a punctal plug that delivers medications. Currently, it's FDA approved to deliver steroids, but they're developing it with Travoprost, and it's supposed to have a 90-day efficacy. Madi Therapeutics, again, another punctal plug that comes on a delivery platform. And so far, studies are looking good there with over 90% retention rate at 3 months. Subconjunctival implants. This is a picture of Duracert, which is developed by iPoint Pharmaceuticals. It's 3 millimeters by 0.3 millimeters. It's the same platform as Eluting, which you may be familiar for treatment of uveitis. It releases over a year, and they're looking at Latanoprost. They're currently in phase 1 and 2 trials. And in intracameral implants, we got a few. One is actually FDA approved. That's Bimatoprost SR, also known as Durista. It was developed by Allergan, now AbbVie. It's a biodegradable implant that's delivered on a 27-gauge needle. And it's on the same platform as Ozurdex. You may have heard of Ozurdex as well. It's an intravitreal injection that delivers steroids to patients with diabetic macular edema and uveitis. And this is what it looks like in the angle. It's very small. I actually was a part of the clinical trials as a fellow, and I got to see these in live humans. And now they've come around to being FDA approved. Unfortunately, we'll go over the FDA results. Basically, they looked at 10 micrograms and 15 micrograms versus timolol. The 10 microgram had almost similar efficacy, but better safety profile. Unfortunately, FDA only approved it for a one-time injection as opposed to a continued injection, which limits its use a little bit at this point. And the reason for that was in their phase 1 and 2 studies, they had zero effect on the endothelial cells. But in their phase 3 studies, especially in patients who got 3 injections, they had a higher than acceptable rate of endothelial cell loss. And different patients have a different rate of absorbing the medication. So some patients at the end of 12 weeks, the implant is gone and you put another one in and it goes down in the angle. But others, that can stay longer. And we had patients in the study that had 3 implants stacked on top of each other because the study was designed to do it every 12 weeks or every 16 weeks, I'm sorry. And, part of the reason why the thought is that this endothelial cell loss happened more frequently was because of that, the 3 implants being stacked on top of each other and damaging the endothelial cells. But the interesting thing was, this medication was supposed to last like 3 to 4 months. At the end of 1 year after stopping the injections, 82% of the patients were medication free. So there was some long-term effect on the outflow of the eye that maintained a year out of injection. And then in patients who only got one injection, 40% of them had IOP lowering at 1 year and were medication free. So that's where I think we can fit it into our treatment at this point is, nothing in glaucoma lasts forever, but if it can last 1 year with one injection, it might be worth a try. This is just a video of insertion of the medication from my colleague, Dr. Paul Singh. This one is actually done in the OR. Usually we do them at the slit lamp. So this one was likely part of the studies because it had to be done in the OR. But basically, you have a 27 gauge needle that enters the anterior chamber, and then the implant is implanted in the inferior angle. Travoprost XR, same kind of thought process. It's being developed by Envisio Therapeutics, and it's still in their clinical trial phase. And then iDose is being developed by Glaukos. This is a little different because it's not an injectable medication. It's actually an implanted reservoir that has medication in it. And I was actually part of the phase 3 clinical trials for this study and got to do a few implantations of this medication. This is a video of a patient that I was able to do the implantation of the reservoir on. And you can see, fill the eye. We make a small incision. I made less than a 2 millimeter incision, filled the eye with viscoelastic. And then under direct gonioscopy, you can visualize the trabecular meshwork and wiggle your way through that small incision that you made. And basically just push it gently in the trabecular meshwork and release. You want to make sure you pick patients with open angles. You don't want to have a narrow angle with the drug stuck between the iris and the cornea, causing more problems. You want to make sure it's seated well and stable, and that's it. And actually, in this study, there was no hyperemia, and IOP lowering was 32 to 33% in phase 2. Phase 3 results aren't out yet. It's pretty robust, and it was designed to work for a year, but in the phase 2 studies, they're seeing that even out to 2 years, a good percentage of patients have effect. So, in conclusion, medical therapy is the mainstay of what we got going on, and it can be effective, but it can be messy and burdensome. And, unfortunately, compliance isn't always the best. You want to do your best to prevent disease progression with the least number of medications and the least amount of burden on the patient. You want to keep the quality of life in mind when you're recommending something. In a world where everything was ideal and you can prescribe anything you wanted to prescribe, obviously you'd go to the most effective medications that are 1 time a day initially, but unfortunately a lot of times our hands are tied with what we can prescribe initially. But also it's important to keep costs in mind too. This is just a list of medications from 2016 showing how much of a cost difference there is between generic and branded medications. New technologies, there's a lot of research and money and investment going into new medical treatments that will hopefully take away some of the issues with quality of life and adherence that we're seeing right now. For now, the most effective medication we have is a medication that the patient will take and will fill and can afford. So we gotta, look at the whole picture at once before we prescribe something. And then, don't hesitate to, refer the patient out to your friendly ophthalmologist, or in some states, you can actually be doing the SLT yourself. So, we have more and more data showing that early intervention with these non-invasive procedures ends up with better results. The light trial, if you're not aware of it, look it up. Basically showing SLT as first-line treatment has clear advantages to starting patients on medication that's first line. So our paradigm, our treatment paradigm is changing, and it's changing fast. These are my references, and I wanted to thank Dr. Wu for including me. And don't forget to join with the next talk. I'm sure it'll be amazing.
Awesome. Thank you, Dr. Saboori, for a great talk on glaucoma. We do have a few questions. Dr. Rebuck asks, with CAIs, we were told in school not to use them with sulfa allergy, but Thomas and Melton, who are some famous ODs in the OD world, said it is not a problem with sulfa allergy. Do you agree?
Totally agree. So the sulfa that most patients are allergic to is a different moiety that you see most commonly in antibiotics and some diuretics. It's different from the sulfonamide that you have in your eye drops. So I rarely have any hesitation. I think the only time I may be a little bit hesitant to prescribe it is if a patient has had an anaphylactic reaction. But chances of crossover reaction is very, very low. And I always have to fight with the pharmacist.
Thank you. Dr. Hassard asks, is the contact lens delivery vehicle going to be replaced every day, or is it a contact lens that's worn for a month?
No, it's a drug-eluting contact lens. So honestly, I don't know enough about it just because it's so early. It's still animal model, but I assume it's not going to be something that's going to be thrown out every day. It may be something that you take off when you sleep, but maybe I would assume it's reusable.
Great. Next question. SLT has been the mainstay treatment in Europe for the last 20 years. Wouldn't that be better for compliance?
Totally agree. And everyone just look up light trial. If it's a simple Google. There's a lot on it.
Next question, will optometrists be able to insert the Evolve punctal plug or just ophthalmologists?
I think it depends on the state, I would assume, but I think in Nevada, where we're at, optometrists are able to insert punctal plugs. So the question becomes, if they have the ability to treat glaucoma, I don't see why not.
Okay. Question from Dr. Cargill, if injection from the medication occurs, is there a contraindication to the long-term injection?
Okay, I'm thinking maybe hyperemia.
Yeah, probably.
Yeah. So a lot of the injection that we see is from the surface administration. Again, the studies we've seen so far with Durista, there is very little hyperemia or injection outside of day 2, which is likely from the betadine that we put in the eye to put the injection in. With the iDose, barely any injection noted in phase 1 and phase 2 studies. So I don't think it's inherently the medication that's causing it. I think it's the vehicle a lot of times, and the fact that it's being put on the surface of the eye.
Last question from Dr. Yokoi. Do you recommend using Lumify for hyperemia caused by glaucoma drops?
So I don't like to have patients use it regularly, but I do tell patients, especially patients who don't have a bromonidine allergy and aren't already on bromonidine, that if they need to use it for a special occasion, then they can use it for that. But I don't like them using it regularly just because, one, it will lose its efficacy, and then 2, rate of bromonidine allergy, even though it's a low dose.
Great. Well, that's all of our questions. Thanks so much to Dr. Saboori again for a wonderful lecture. Thanks to all of our in-person attendees. And we did have almost 1,000 eye doctors log in for this presentation to hear from Dr. Saboori. We do have another WooU event tomorrow. It is a implantable Collamer lens update with Dr. Brian Boxer-Wackler, a very famous eye surgeon in Beverly Hills. So if you're interested, please sign up. And hope everybody has a good evening. Good night.